Hello and good afternoon. This is Manos Brilakis from Minneapolis Heart, and it is my pleasure to welcome everyone to tonight's webinar about how to optimally use intravascular and coronary imaging as well as coronary physiology. There's CME for this webinar, and you can actually get a CME on the CVI website. And we have a distinguished faculty, great friends and great operators with a lot of experience in imaging and physiology. Dr. Abdul Hakim from Rutgers Robert Wood Johnson Medical School in New Jersey. Dr. Haider Hassim from the MedStar Washington Hospital Center. Dr. Arnold Sito from the Long Beach VA Medical Center. And Dr. Poonam Belakapudi from the University of Nebraska Medical Center. Again, welcome everyone. We're very excited to look at the cases and discuss them. These are very informal questions and answers. Please, from the audience, anyone who has any questions, feel free to put them on the chat line and we'll discuss them online or answer in writing. We'd like to thank the sponsors, Abbott, Boston Scientific, and Medtronic. And this is the link, but again, if you go to the CVI website, you can find the link for getting CME. And also don't forget that in a little over a month, we'll have the actual in-person CVI, the first time after 2 years, at the High Regency in Denver, Colorado. So with this, I am going to stop here, and we will get started with Dr. Haider Hassim, who's going to show some cases of coronary imaging, an area which he's done a lot of work, and he really has tremendous expertise. So Haider, thanks again for joining us tonight, and we're excited to look at your cases.
Thank you so much. So thank you, Manos, for the invitation. I think I'm going to try to put this in 10 minutes. There will be questions throughout the case, so for you to help me moving with the management. So I named this intravascular imaging in the era of. I do believe that there is a component besides angiography to classify and risk stratify our patients arriving to the cath lab. These are my disclosures. I have this 6-year-old gentleman, hyperlipidemic, hypertensive, BMI of 23.6. He's a hiker. He's always out and about. Has some exertional angina while hiking, mostly uphill, for many months. But he continued to exercise through, rest, and keep going. Had one episode when he had resting chest pain that took him to the emergency room, and they did cardiac biomarkers, silent EKG, and they discharged him from the emergency room to follow up with a cardiologist. Had the family history of premature coronary disease, and he was already on atorvastatin and metoprolol given to him by his cardiologist. He's allergic to aspirin with an anaphylaxis. This is a true allergy to aspirin. This was his resting EKG when he saw his cardiologist. Nothing of significance, and has the same exact EKG when he had the resting pain visiting the emergency room. And as you know, following ischemia trial, most of our patients nowadays they are deviating away from functional testing into more anatomical testing and definition by CT scan. And here you see a CT scan of the RCA and the circumflex. They both appear to be free of any significant coronary disease. But when we did the LAD, right at this mid-distal LAD, you could definitely see this non-calcific atheroma involving this side of the septal side or septal portion of the LAD. And this was quantified as a moderate stenosis of the LAD.
And if I can say, actually, I'm glad you're showing this case. Increasingly, similar to you, increasingly for us, we are seeing people come to us straight from the CT. So I think it's becoming essential for us to actually understand how to use CT. Don't have to be, a world expert on analyzing, but looking at the images as you are showing us now, understanding what is the lesion, what is the plaque, I think will go a long way, probably become an essential skill, same as reading the angiogram. I don't know if other people have the same experience, but this is what it seems like it's going to happen, or it's happening already.
True. I see it more often now, and then we're using our TAVR work, and because with TAVR you need to be CT savvy to kind of rotate the heart to find the annulus, to check the LVOT. So that's very helpful skill when we look for the arteries. These pictures one of my fellows was able to extract from a raw data from CT scan, but we're now able to kind of cut through good planes and get the pictures. Manos is spot on. So anyways, this is the 50 to 70% moderate lesion. So his cardiologist said, you know what, I just want to see what happens to you. You have a normal resting EKG. Let me see how much you can do and if I can provoke symptoms in you. And here we go. He did 10 minutes, exercise for 7 minutes, and he has ST depressions and chest discomfort. Now, what's the plan moving forward? You are the cardiologist. You have a CT scan with moderate lesions. You have angina. This is your typical. Do you reassure and end it there? Because anatomy, it's a single vessel CAD, and it's only mid LAD. That's 50 to 70. Do you reassure it here and intensify his medical management if you think there is room? He's already on beta blocker and atorvastatin. Do you want to add something to it? Would you use CT-FFR in this scenario? Or would you send him to coronary angiogram? Arnold, do you want to take this?
Well, I mean, you've already established ischemia theoretically with your stress test, but he has made 10 mets, so you could go with medical management. I think it's really a dealer's choice here, up to the patient. I mean, you haven't talked about angina management, but I think it's really up to the patient at this point. Do they want to live on with medications for years, or do they want to get stented and take care of it? You know how we all feel about it as interventional cardiologists, but we always have to approach the patient and the referring doctor.
That's true. Awesome. Good. So he was sent for an angiogram. After discussion with the patient said, you know what? I just want to make sure that I'm not sitting on something crazy in my LAD. This is his right coronary artery view, and this is his circumflex, similar to what the CT scan had told us. And this is his LAD, right between the first diagonal and second diagonal. I think it's obvious to everyone that there is a lesion right there. It doesn't appear to be calcific on the initial frame of angiography. Now what? You said, you know what? Your angiogram similar to your CT scan. Just keep going, man. You're doing good. Keep going. Now I see it even better. Let me intensify medical management. Do you want to take some nitro? Do you want to do something else? Is it time to do physiology? Because we didn't do CT-FFR. Do we really want to see if this is an FFR of 0.67 or it's an FFR of 0.82? Is it 0.85 or it's something else? Would you IVUS it? Do you think imaging will make you risk stratify this LAD, or would you even OCT it? Manos, do you want to take this? I'm saving
first of all, let me remind everyone, we're doing a webinar on intracoronary imaging. So then by definition, the last two options are going to be correct. But apart from that, I guess the question here is more about the patient with having rest symptoms, like having rest pain. And he does have this intermediate lesion that looked actually kind of vulnerable on CT with a soft component. So in my mind, OCT is probably the better way to go, because you can look for areas of vulnerability. Is there any thrombus, any rupture, anything that might actually make us be more likely to do this patient. And if the patient was completely stable, we can do physiology as well. But I think here, in my mind at least, we're looking more for a cause of the patient's rest symptoms.
Perfect. So for the exact same thing, I'm trying to challenge ischemia trial with this presentation. Not that I'm not a believer in data, but I just wanted to always keep everyone thinking that there are more components to the decision-making than it's a mid-LAD lesion on a CT scan with angina and go home. So I did physiology testing. I was right there. I said, you know what? Let me see if it's truly this is the cause of his ischemia. I'm not sure. So I did an RFR, and my RFR was 0.90. The cutoff is 0.89. So I was like, oh, hold on, what's happening here? Let me induce hyperemia. And I did induce hyperemia, and here we go. My FFR is 0.76. Now, have I done this in borderline physiology? I'll let Abdul talk about physiology, and probably he will answer this question. In borderline resting non-hyperemic indices, when I do the measurements, if it's 0.90 and I put that in the clinical context, I do believe that if you induce hyperemia, you can provoke a more distinctive values for you to make an easier decision. Now, as you see, I'm using the core flow system, or I'm using Abbott RFR non-hyperemic index, and I'm already there. So I said, you know what? I know there's 30 to 40% of patients with microvascular dysfunction despite the fact they have epicardial disease, and they continue to have chest pain despite the fact you put a stent in their LADs or their circs. I'm right there. Let me just do my coronary flow reserve and then my IMR. And as you see, the CFR was 3.2, which is, I can't make any comments on this, but we know from data Bill Fioran presented and published on many times that CFR of more than 2 or 2.5, you're in an okay place. And then IMR is more specific for microvascular dysfunction. And if it's above 25, then you do have microvascular dysfunction. Here we have 21, so I excluded microvascular at least for this presentation, and I'm dealing with only epicardial disease. Now we have the FFR. And do you say, you know what, your FFR, your resting was fine, your hyperemic was right there, 0.76. Some trials talk about 0.75. I'm going to leave you here. Now I know what your lesion is, but I'm going to add more medications to you. Or do I have enough data now to put a stent in you? But if I put a stent, you are anaphylactic to aspirin. Now what? Would you proceed with PCI, giving him P2Y12 load? Would you stop and desensitize to aspirin? Okay. So, Paul, I'm going to take this. Sorry, I hate to call on people, but.
No, that's okay. I think in my mind, it's really important that we have a definitive answer at this point. And so I think I would proceed with the PCI and do the P2Y12 load, and then you can always desensitize to aspirin as an outpatient. And I really think that right now, for the high-risk patients and stuff, we do have enough data to say, one agent may be okay, right? So I would do something right now.
Cool. So what I did was very similar to what you did. I put him in holding. I stopped. I said, you know what? I'm just going to stop now. Let me discuss more with you. I discussed with the patient, and we have an opening in a CCU bed. So I put him in a CCU bed. I got him desensitized to aspirin. And now he is not allergic to aspirin anymore. And I brought him the next day. And that's what I'm going to try to kind of reach into the future and talk about what I believe the next time we do a PCI, you either have a full physiological assessment with microvascular dysfunction assessment, or you need to really know what vulnerable plaque is. This is IVUS NIRS. I'm going to let it run. It's a 60 megahertz. It's high definition. We have it in the lab. As you see, it's color coded. Red means there is no lipids. Yellow means there is lipid burden index at 4 millimeters of more than 400. And I'm gonna talk about it in a second. It's a way for us in Prospect trial and LRP. That's what we used to define vulnerable plaque and plaque that has high risk of future events. So if you have an LCBI, lipid core burden index, over 4 millimeters of more than 400, that's the value that's associated with bad outcomes and futuristic events. And as you see here, the plaque was quite extensive in this patient. Distally, you see very good distinctive layers of intima and media. But as you approach here, you definitely see very thick plaque. It has this vacuole appearance to it, quite lipidic based on the color code. So I knew that this 50-60% angiographically and physiologically, now it's even more vulnerable with lipids. And here we go. These are the numbers. So I just do the measurement just like you do with any longitudinal section on IVUS. I have a 13.7 lesion. I'm now thinking 15 millimeter stent, and I know that my LCBI over 4 millimeters is 562. So there's enough disease in that area for me to say that this is vulnerable plaque. Because I love OCT and I'm already there, I decided to go with OCT. And the reason he consented for one of our trials that we're trying to use OCT, given that it's more readily available, that OCT can predict lipid vulnerability and lipid core. And as you could see, probably a few frames that passed along, you could see that this lesion was definitely lipid rich and ready to rupture at any time with very thin fibroma. So I went ahead and I put a 3.5 by 15 stent. and did my post-OCT, and here we go. We have full opposition. Definitely there is evidence of lipid everywhere. We landed in a good spot. There's a lot of tissue protrusion, talking about how lipidic this plaque was. But I felt that integrating physiology, integrating IV smears, now I think taking those patients based on ischemia trial with angina and single vessel CAD on stress on CT scan is not enough to make a decision. And I think the future will carry more interrogation before we make a decision to put any stent. And with that, I'll conclude. I'm probably a few minutes over.
Oh, this is perfect. Thanks. Actually, I think this is probably the most characterized patient in the U.S. for this year. I mean, it's amazing work on getting the full imaging, physiology. I mean, pretty amazing work. And I think many people are not familiar with near infrared. We've worked for many time, but I think it's become much more popular now, and that can really help you with lipid assessment, as can OCT. So I guess eventually the conclusion here was that the patient here did have ischemia based on the physiologic testing, right? So that was the end of the day. What happened? And I'm curious on Arnold's thoughts. I know, Arnold, you've done a lot of work on this when you have the one index is non-really ischemic, the other one is ischemic, and a lot of confusion in that area. Can you explain to us in 30 seconds so everyone can understand what is going on?
Yeah, this is a great case. I mean, you had a borderline negative RFR, you had a borderline positive FFR, you actually had a firmly negative CFR, and then you used coronary imaging along with the physiologic testing non-invasively to help push you towards the intervention. I really think it becomes dealer's choice in these matters when it's in these intermediate ranges, and you use your best clinical judgment. Stick with the patient who has symptoms. This patient has symptoms. You talked over what he should have, and you thoughtfully went through his options. So I think you did a great job, and I'm not sure I would ever go to aspirin desensitization, but that's another topic of conversation.
Sure. Abdul, you also have a lot of experience with physiology, and what would you do we've done in this case? Would you have done the hyperemic one? Would you have done anything different?
I think this is a classic frame 2 patient. Like Dr. Cito said, he had angina, he had a positive FFR. I think Haider did a very elegant intracoronary imaging, first with an IRS and then OCT. But I think given symptoms and positive FFR, I would have gone ahead and stented. The only question I had was you knew going in that this was in all likelihood going to be physiologically significant lesion. Why wasn't aspirin desensitization undertaken ahead of time?
We lost the last portion, Abdul, but I think the challenge here, patients in Washington, D.C., they're quite educated. He came, he said, I have a single vessel coronary artery disease. Yes, I do have symptoms, but I know there are trials telling me that stents are not the right option for me. So that was the whole debate that I had to deal with referring cardiologists as well. Because by God, if they read the ischemia trial, it's a single vessel. They were all ischemic on stress test. They actually got to the lab. It's almost like a Courage patient. If we go back to Courage days, this is a single vessel artery, moderate angiographically. And in Courage, they just got medications or get stented. So that was the main challenge. I couldn't even justify to the patient that I'll bring you and desensitize you in the CCU, because he was like, do you really think I need a stent? Because my CT told me it's a moderate lesion. It's a single vessel CAD. Why not just do something? And we debated this for a long time before I even put them on the table. I'm showing you the last step of of many visits, but this is what we ended up doing. I had to convince him step after another, present him with data that this is vulnerable plaque, physiologically positive, for him to go through the desensitization and accepting a stent for a single vessel CAD.
So if let's say the FFR was 0.82, would you have done imaging or would you have just stopped there?
Yeah, I probably would have done imaging. Truly, I do believe in imaging, because where I'm coming from, our lab is now, we're heavily invested in futuristic approach or forecasting vulnerable plaque, which plaque could cause a problem. Ron and myself, we were in OPCI over the weekend, and he presented on vulnerable plaque and risky plaque. So we're doing this. If I see a lot of lipid in an LAD in a young man like this or a young woman, I probably feel strongly to fix it if it's borderline FFR.
Perfect. So there's in use of time, maybe we should go on to Poonam's cases, and then they can debate this a lot. But again, I think excellent case, Haider. Thank you so much, and Poonam, looking forward to your cases.
Okay, can you see my screen? Awesome. Thanks for having me, Manas, and nice to be here with so many other colleagues. So these are my disclosures. I'm going to do quick presentation of 2 or 3 cases as time permits. So in my mind, I think the imaging is the brain of PCI, and so whatever we do, whether left main or ostial bifurcation, calcium, stent optimization, stent failure, ACS, ambiguous angiograms, intracoronary imaging is really, really important, and it should be a part of our daily PCI. This is a 37-year-old young patient who presented with NSTEMI while he was waiting an outpatient cath. So his history is very significant for a VT-VF arrest about less than a year ago, had ECMO, 99% LAD, diag disease, and he had stents in an acute shocky situation. And he's also an end-stage renal disease on dialysis. He was having accelerating angina over a few weeks. And so a stress test was done with 10 segments area of ischemia in the LAD territory. And that's his creatinine, and his troponin at this presentation was rising from 2 to 4. And this was the point where we had to cath him. So this is his right side. So you can see there's about a 60-70% proximal RCA lesion. And then this is his left system. So you can see that the LAD stent is 100% occluded. The diag stent has 99% stenosis and quite diffusely diseased. So at this point, the discussion was about what do we do? It's a young patient, has this stenosis in the LAD diag stents, and then also the RCA disease. So what would, anybody, what would you do at this point?
I guess he's not a good candidate for surgery, right? I mean, it looks like 37, but a lot of comorbidities, dialysis. So, I mean, I think this is a complex PCI, but I would probably think PCI might be the better way to go. I don't know, Haider or Arnold, any other thoughts?
I'll probably present him to the surgeons just to get the blessings, They deny him, then we will have to think. The problem is he already, Manos, this, he demonstrated ISR already. Makes his second layer stent a bit challenging, but sometimes your hands are tied.
Yeah. So we did have a good discussion. These stents were placed less than a year ago and in a shocky situation. And we know in the setting of ischemia, he had VT-VF arrest and his significant morbidity. So we decided to image and see what the failure mechanism was on imaging. And so went ahead and IVIS both diag and LAD. And so this is the IVIS image. So this is the eagle eye volcano. It isn't the best, but this was what I used at the time. And you can see that there will be some underexpanded stent. There's some calcium. And as we go up into the stent, there's a lot of neointimal hyperplasia as well. So let me drag through this. You can see that the, so here's this stent, called that neointimal hyperplasia. And then you can see that there is, again, significant disease. So that was the diag. I will move to the LAD and let this play here. And he did have underexpanded stent in certain areas, and then also had a lot of neointimal hyperplasia. as well. So at this point,
Poonam, do you have brachytherapy at your place?
we do not. We send them out, but this was only one layer of stent. So if we stent now, this would be a second layer. So I think we still have some ways to go, don't you think, for brachytherapy?
Yeah, absolutely, absolutely. Just thinking in the future.
Yes, yeah. And so I'm going to so again, all the neointimal hyperplasia, and then the figure of interest is on the right. There was some underexpanded stent, like right there. You can see there's a lot of calcium. And so, like I said, if it was a mechanical problem, we thought we could always, fix this time. And then if he has a problem, he's still a candidate for CABG in future. So stent sizing, both diag and LAD were 3.5, distally as well as prox. And so from here on, it was a straightforward. So anterior wide escalation in the LAD. I usually try and do DK crush when I have equal sized vessels. So the stent in the diag, crush the stent, and then open the side struts as an extra step, and then stent in the LAD. Kissing balloon inflations, POT. There's that distal disease that I had actually thought I'd leave it alone, but it looked pretty significant after the stent. So another stent there, and then that was the final image. So he did okay. He did not have any more ischemia. His symptoms resolved. But unfortunately, like you all said, he has the bad protoplasm, and then he did come back later with again 100% occluded LAD, and so at that time we sent him for surgery for CABG. So did not do brachytherapy, Manos.
And this expanded with just ballooning, the LAD, the under-expanded areas were just expanded just with the regular balloon.
Expanded very nicely with the NC balloons, and I believe I used a cutting balloon as well in the diag.
So again, it was just an issue of, I guess, standing without imaging guidance in the beginning, right? To make sure it's well expanded, do you think?
I think it was, the stents were placed when he was in shock, and the stents were probably undersized or underexpanded because it wasn't done, in a perfect way. So I think that was the mechanical issue at the time.
Perfect. I don't know, any other thoughts? I mean, Haider or Abdul or Arnold, any other thoughts about this case? Anything different, or you think this was done as it should?
Yeah, I think this patient should have gone to CABG up front. This is a young guy, as we know. ISR in about a third of cases is not clinically silent and presents as an ACS. So the stents failed. Yes, there was a mechanical cause for it, as is often the case in of shock. We often tend to undersize stents because time is of the essence, and we don't image and do things the way we're supposed to. But he had stent failure in less than a year, so so maybe sending him to surgery up front would have been one option.
Yeah, I think for the audience, I think Manos and Dr. Sita probably you both agree. For ISR, imaging should be class 1 indication. Truly, there's nothing worse than putting a stent in a badly deployed stent to start with. I think imaging should be the way to go with any case of ISR. Without understanding why the stent failed, there's no way you can pick the treatment. Do I prefer IBIS or OCT? I usually prefer OCT. It gives you more of the composition of the tissue. You understand what's hyperplasia versus what's new atherosclerosis. Obviously, the timeline also talks about this. This is not a Cypher Select from 2006. This is obviously a stent that we just put in a year ago. And the most common type, when we looked at our data from all brachytherapy cases we've done over the years, most common type is the mixed, which is the biological because of a mechanical issue. That's the most common type. You rarely see biological only unless someone is allergic to the stent. Mechanical usually is a stent fracture or under expansion. But once you have under expansion, then you will form tissue. So you go from mechanical into mixed biological and mechanical. Brachytherapy is effective. We have some data on single layer brachytherapy. We do that especially in vein grafts, just as a last resort before we open the CTO, just to temporize things before we open the native CTO.
Just because we brought the issue of CABG, this patient could not get a lima for some reasons during surgery, and he got an SVG to LAD. So we also have to keep that in mind, right? How long are SVGs going to stay open? Of course, if it was a lima, it's lifelong, but SVG is what, 50% at 10 years, and if it's a CTO, it's much lower, maybe 25 to 30% range. So I think we send all these patients to CABG, but those are things also that we need to keep in mind as well. So a good PCI with imaging guidance is definitely something that I would consider the first time.
Especially in dialysis, if his fistula is on the left, the lima becomes a really tough issue to build on an arm that has a fistula. Great
and
point.
Also, what's the long-term prognosis here, right? I mean, 37 on dialysis. I mean, the reality is, I know he's young, but I mean, it does not look very promising. He's going to have like 20, 30 years ahead, unfortunately. So,
that being said, I think Poonam, you did a good job giving him a chance. Even if it's less than 50-50, you gave him a chance to save him from the surgeon's knife, and no harm done, I would say, because you gave him a chance to recover from mechanical failure of the stent.
Yep. So this is a 91-year-old lady who is living in an assisted living facility, and she enjoys doing exercises with her groups. And so she started having shortness of breath and fatigue, and had a DSE with 3-segment ischemia in the anterior and anterolateral segments, and couldn't participate in her exercises. So she's 91, 92, family, and she did not really want to do any, aggressive measures. But ultimately, because of, she's not able to enjoy what she's able to do before, they decided to move for a cath and only do something if it was a significant disease. So that's the RCA, and this is the LAD. So more pictures of the LAD. And so at this time, given that there was significant proximal LAD disease, decision was, after discussion with family and patient, to move forward with an intervention here. So if you look, it doesn't look super calcified. I mean, when the dye goes off, we don't really see much. And so, as always, I do a quick pre-dilation and imaging, which I play here.
And this is the LAD pullback?
What's that? Yes.
This is the lady, right?
This is the LAD pullback, yes. And so there is some calcium, some places more than 180, maybe even up to 270 degrees. You can tell the thickness on the ibis, obviously. Lengthwise, yes, about 4 to 5 millimeters. And really the tightest part was about 2 to 2.5 millimeters. So this was definitely a balloon crossable lesion with calcium. And I know I could, so the next step we were thinking was—
maybe should we ask, I guess maybe just take a minute and ask, like, Abdul or Abdul, would you do a atherectomy here based on what you saw? It looks like there's maybe a calcified nodule or something, there's a lot of calcium there. Would you do a atherectomy on this, or?
I think because she's 91, I would just try a balloon, and if it yields nicely, I would proceed. Lesions that really need rotational atherectomy, they declare themselves. As we all know, yes, imaging helps, but the ones that truly need atherectomy would declare themselves, especially she's 91. if I can get a balloon to dilate nicely and put an appropriately sized stent, that would be my strategy. If this was a 68-year-old, I would be more aggressive.
Exactly.
Yeah, excellent points.
Yeah, so that's what I did an NC balloon. These are the sizing again, 2.5 distally and 3.5 more proximally. However, the smallest size was about 2 to 2.5, and the NC balloon really didn't open it up very well. And so I decided to use a shockwave and did a couple of, I did the full 8 cycles all the way where there was a calcium. And after that, you can see that is after the shockwave, and then the balloon nicely opened. And now just used a single stent, 2.5 from distal to proximal. We have the 48mm length. And so here is after stent and post dilation. This is the IVUS.
Perfect. So you protected the side branch with a wire, and
yes.
You did a pot. It looks like a balloon, the whole thing more proximal, larger balloon. So that's an excellent technique.
Yeah. So that was pretty well opposed, and there was some proximal disease, but didn't want to go into the left main and make it a complicated issue. It didn't look more than 30–40%, so I just left it alone. And so that was the final result. The diag is a little bit pinched, but TIMI3 flow, really no issues there. STs were okay and no pain. So we quit there. And then this is my final case, quick 2 minutes, 60-year-old, very obese male with distal anterior and inferior hypokinesis, significant symptoms at rest. And this is the CAT, RCA, just some mild to moderate disease. But this is the LAD. You would think that this is probably going to be a straightforward lesion, wired it, and did a quick compliant balloon inflation, 2.5 by 15. And immediately patient starts to have chest pain, ST elevations, blood pressure starts to, tank. And so you think of all these differentials. I quickly did a 1 cc puff and no flow in the distal vessel. So then IVUSed it, and here is that IVUS. And he's complaining of a lot of pain at this point. STs are floridly elevated. And then BP.
Actually, I must say, I'm impressed. You took the time to do IVUS when the patient is not feeling the best, but I mean, obviously it's very helpful.
Blood pressure is still stable. Well, in the meantime, they were already we pulled the stents and everything, and we were getting ready to put the stent in, but I just wanted to, see if there was any major perf or anything. It was just out of proportion to what I thought had happened. So.
This would have been a great case for Hashim to do an NIRS on and show the liver.
Because I think it's there's a lot of stasis.
Yeah. So, any case, it was definitely only a dissection like I had expected. It wasn't very long. I knew exactly this with the IVUS. I could do the measurements quickly, the length. And then so put those 2 stents in distal to proximal, and then dilated it and all that stuff. And then finally, this was the result. He did okay. STs immediately resolved, chest pain's gone, and he was fine. He maintained his blood pressure. I mean, it was soft, but it was still okay.
That was a beautiful large hematoma, right? So it's interesting that he had such a rapid progression and such a large hematoma so quickly, but I guess it happens.
Yeah.
I think it's the lack of calcium. Dr. Balakis, you know this very well, much better than any one of us. In CTO, the subintimal space doesn't expand fast in calcified arteries, but in soft plaque like this, you could have a hematoma as you're still talking to yourself through the algorithm of what to do. I think imaging in cases like this is very important, especially with IVUS, because it's at least you understand if it's a no reflow or if a mechanical issue, because the treatment is totally different. instead of pushing adenosine and epinephrine trying to resolve no reflow, it's a dissection. You tuck the flap in and then you establish flow and you abort the story. It's nicely demonstrated. It's beautiful.
Yeah, and I also think you should understand from the distal end, as you did, to cover distally so the hematoma doesn't go distally and compromise the vessel. So again, very, very well done. But maybe we'll move on to to Arnold Sito is for the next presentation. Thanks again, Poonam. They were excellent cases. Thank you so much. A lot of good lessons there and beautiful images of the anatomy there. So Arnold, thank you so much once again.
Great. Yeah, it's hard to follow up such great cases. I'm jealous of some of the technology I'm seeing. These are my disclosures, and great job to all of you. I just want to go over some of the latest advances that we are fortunate to have in our lab, but also are available in other labs. The Philips has this new Omni wire, which is a solid core wire instead of the eccentrically placed core of the traditional Virata pressure wire, similar to the OpSense wire. So these special wires really have a lot of crossability now and pushability. In this particular patient who had sort of a CTO, we were able to get this Omni pressure wire actually straight across the lesion without difficulty and finish the intervention. Another example here, this mid-LAD calcified lesion, I'm pushing and pushing with the Virata wire. I can't get it past the lesion. The sensor just seems to get stuck on the calcium, but the Omni wire is able to cross easily. That's just an example of what you can do now with new technologies. In terms of co-registration, I'm showing you this case, a 71-year-old man with hypertension, hyperlipidemia. He's had a CTO PCI in the past. He comes back with chest pressure with exertion, improves with exertion with sublingual nitroglycerin, but it's increasing in frequency. He's had some shortness of breath and requests clearance for colonoscopy. Here you see a patent mid-LAD stent, but proximal to there, you might see a concerning lesion, but at least on the areocaudal, you can't really see it as well because of overlying vessels. So there's a question of an LAD lesion, but it's either foreshortened or have some overlying vessels on the angiogram. So what can you do? When you do a pullback with an IFR wire, you can see a pretty steep pullback gradient of 0.79 into the lesion. And so that's easily stented. But what about that ramus lesion? You can see here in the ramus branch, you have a fairly two large branches come off of it. So you don't really know, where should you be stenting into in this bifurcation? Both vessels look equally bad. So which one is the main branch? Well, you can do a pullback from each one. In this case, the upper branch has an IFR of only 0.90, whereas if you go in the lower branch, it's 0.84. Again, two similarly sized vessels, presumably similar territories, but the IFR is markedly different. You can ignore where the dots are. The dots are actually distal to that bifurcation. Obviously, it would have been affecting the upper branch had it truly been that far back. So this gives you some information. This co-registration really tells you that you actually should be stenting into the lower branch, and that's what we did. We stented in the lower branch. We actually trapped the Virata wire into the upper branch, and we could get a post-PCI IFR of 0.90 still in the side branch, so no effect from the stenting, which is very nice. Not to bias towards Philips, but here's our latest technology. We acquired the CoraFlow. We have a 75-year-old asymptomatic man with a decrease in his EF. He has a calcified, diffusely diseased right coronary artery. It looks pretty bad. Should we go ahead and do a shockwave and a stent? Well, as Hyder showed, you now have the Corventis CoraFlow system with Abbott wire. You can show that the FFR in this case is borderline negative. The RFR is negative. The PDPA is 0.93. But importantly, the CFR is 3.8, where normal is less than 2.5. Normal is greater than 2.5. So this gave us the reassurance that even in this diffusely diseased vessel, you didn't have to go with a complex intervention with calcium mechanisms, but rather you can just leave him alone, which is quite a bit to walk away from. Someone with a low EF with a lesion that looks doable, but the better part of valor was to leave him alone. So those are some of the newest technologies, of course, CoraFlow and then co-registration from Philips. I do want to remind some of us of the limitations of physiology. I speak about physiology all the time, but there are some wires that just aren't meant, some vessels that aren't meant for physiology. This is an OpSense wire that's successfully crossed, but what you see is that it creates actually some pseudo lesions. And these are, these lesions weren't there in the beginning, but because of tortuosity, the wire itself can create pseudo lesions that ultimately lead to acute vessel closure. Fortunately, this resolved upon pulling back of the wire. So sometimes the wire is now so good that it can go like a run through or workhorse wire, and you get into places that you don't want to be.
When you see that, Can I ask, I'm sorry, so when you see that, then if you measure a index, right, it's going to be significant, right? So
Absolutely.
The problem is physiology then doesn't apply when you have these very tortuous vessels, right? That's always a word of concern, of caution.
Absolutely. In some of the trials, we excluded severe tortuosity or calcification, partly for that reason. Other limitations of physiology here, we're using the assist system, and in this complex bifurcation, trifurcation, or quadrification lesion, you can see here that the LAD FFR is positive at 0.75, the diagonal is negative at 0.87 FFR. So you think, well, maybe I don't need to use this as a two-stent solution. It looks bad angiographically, but physiologically, the diagonal looks okay. So what do? You fix the PCI into the LAD. Then sure enough, the PCI, the post-PCI diagonal physiology is now plummeted to 0.59. I mean, this is plaque shift in its essence. So this was eminently predictable, and you can't just rely on the physiology to predict that type of thing. So of course, then you have to go on to kissing balloon inflation, and then the final LAD FFR and IAG FFRs are negative. But the advantage of the assist system is that you can then, with leaving the wires in place, instead of doing multiple pullbacks across stents, you instead are able to push the sensor across the lesion.
And I can ask you something. Many people jail the wire, right? And people are always concerned that the sensor might get caught up on the side. How concerned are you for that? And you think it's just fine?
So I showed how I did that for the Phillips wire. For the Verada, that is a concern. It depends on the slot shape. Apparently, some of them are rounded, and one of them is straight. The Verada wire, you should not do that to. This is an assist catheter. Obviously, it's not going to get caught, so you're good. So it's generally discouraged, but so far so good. I haven't had any trapped, and often it won't pull apart. I mean, they say you can actually twist the wire, rotate it out, and maybe another option could be to partially deploy the stent before pulling back. My last case here is a 71-year-old man with a prior LAD stent and angina, and he has this really severe right coronary artery lesion, look 80-90%, but we do physiology on him, and even though he has some in the initial echo was wrong, his EF is actually pretty good. We do an IFR, and on this 80-90% lesion, the IFR is completely normal at 0.97. So you think, gosh, can I just stop and walk away from this? Well, then you do physiology, you do IC adenosine, 90 micrograms, and you still get a relatively borderline negative FFR of 0.84. So what do? You say, well, maybe I'm not delivering enough. Maybe let's just hit it harder with more adenosine. So you give more adenosine, same thing. You give it intravenous, same thing. You have two negative physiologic markers. You have a terrible looking angiogram. What do? He has chest pain. And then you do this, I let him go. 2 years earlier, I found the exact same numbers, and he still came back for chest pain. Oh, just mild, 2 out of 10, but he has some shortness of breath. So he came back, same numbers, same measurements. Well, now this time we do imaging, and you can see here this 89% lesion. It's really ulcerated looking in a large vessel. So we violated our oaths of physiology gods and said, okay, we're going to stent this. With co-registration, you can find the exact length that you want to stent to, and then we stented it. We had some complication where the bad guide support, of course, and then deploying the stent led to us rewiring into the side bench of the strut. And so you can see here we displaced, unfortunately, we came out of the stent, we exited the stent with a rewiring, and therefore had to actually place another stent to find the location of the wire exit, and ultimately needed 2 stents to finally fix this lesion. But with the IVUS co-registration, we were able to determine exactly where we had exited the stent. So this demonstrates one example of where IVUS co-registration, which is not that useful most of the time, but here's an example of where it actually was quite useful. And of course, as they all do, the next day the patient reported full resolution of his symptoms and a breath of fresh air. So it felt good, even though I violated my oath to FFR. So in summary, all the new physiologic offerings, you saw that we had 4 different companies that we showed here. They all have different roles, including FFR, non-hyperemic pressure ratios, and CFR. They make it easier to measure physiology, but ultimately physiology is just one tool along with imaging for your clinical judgment. So you shouldn't be locked in to doing something just because of the physiology. Thank you.
Yeah, thank you, Arnold. Again, phenomenal cases, very a lot of learning within a few minutes. But I think it's important to say, as you say, that the pressure wires can go places now that they couldn't go before. So be careful how you use them, and then always use your judgment, I guess, right? And in my mind, the borderline, the FFR of 0.81 or 0.82, or the RFR or DPR or IFR of 0.90, 0.91. I mean, you always try to keep it in a continuum, because it's not really a hard cutoff. It's more of a continuum of ischemia from 0.90 to 0.89, etc.
Yeah, we should tell that to the AUC folks, right? That's the challenge, because we're judged on that. So you can do that sometimes when it clinically is relevant, but if you do it all the time, then you're going to get cited. So.
Actually, yeah, I had a peer review once for studying an IFR of 0.90. But anyway, I mean, it's one of those things you don't understand. So again, excellent. Thank you so much. And then last but not least, Dr. Hakim is going to present to us some more cases of coronary physiology. So Abdul, thank you so much.
Thank you, Dr. Boulakis, for the opportunity. I hope you can see my slides. So I actually only have one case, but I'm sure it's going to generate a lot of discussion here. I do not have any disclosures, which is quite unfortunate. But so 66-year-old, this guy is visiting from India, and he had an acute MI sometime in 2003. Had a stent placed to his LAD. Then he presents to us with acute decompensated class 4 heart failure. Per records, he had a cath in 2016 where the LAD stent was patent and the RCA and the OM2 and 3 were occluded. His EF is known to be 25-30%. He has fairly advanced Parkinson's disease, COPD, and he presents to us in flooded heart failure. He was diuresed, and we got an echo, and you can see his LV is dilated. His ejection fraction is really reduced to 15 to 20%. So given his history of CAD, once he was stabilized from a heart failure standpoint, he was brought to the cath lab. So my first question for the experts here is, what kind of stent is this? It's a stent that was placed about 19 or 20 years ago in India in the setting of an acute MI. It's got these two markers at the proximal and distal edge. So I looked it up online, and I think back in the late 90s, they would put these gold markers, so they became. So this is probably one of those. But as you can see, the right is per history. This angiogram is similar to about 6 years ago, and the OM2 and OM3 are also occluded. So that is LAD, massive septal perforator supply. Lots of collaterals to the right. And there is some degree of
Yeah, I think we're losing a little bit, but I mean, you can see that again, you have a CTO of the right, the lady has some disease, but it's hard to tell what is coming from the right. So just curious, so what, so Poonam, what would you do for this patient? Would you?
Yeah, since the LAD is supplying so much collaterals, I don't know if the physiology is going to be indicative just of the LAD, because I think, when you fix that CTO, then the physiology might be different. So I think have a discussion with the patient. I mean, I could definitely image that lesion, but without a physiology, really, imaging wouldn't really mean anything unless it's way too significant. So I think I would start with physiology, though I don't know if I would trust it very much, but have a discussion with the patient as to what the long-term, should it be a PCI or should it be a cabbage? That LAD will be significant by physiology, it appears.
Yeah, absolutely. And I mean, it's well known that, if you stent, as you said, the CTO, then the FFR of the donor vessel will increase by 0.03 to 0.10, so it can have a significant impact on what your FFR on donor vessel is going to be. So Abdul, what do you guys do in this case?
So, well, at this point, we just, because he had two CTOs, high-grade OM1 stenosis and instant restenosis, the LAD, we did an FFR, and I'm not sure if you can see the entire screen. So resting index would be in the ischemic range, and its FFR was in the gray zone if we by 0.80. So at this point, we stopped because he has, and this was deemed as ischemic cardiomyopathy. We asked our heart team, copied and pasted the note from our surgical, reviewed by 3 different surgeons. And the reasons the effect because he had advanced Parkinson's, and they asked us to do one study. LV was dilated. They weren't sure how much benefit we get out of CABG. So this was discussed in the CT surgery conference reviewed by 3 different surgeons, and they said, get a viability scan. So we got a viability scan with thallium, and a part of the apex and the entire inferolateral wall, which would have been the OM2, OM3 territory, were non-viable. Most of the inferior wall proper and the anterior wall up to the apex were viable. So we brought him back. We stented the OM1, recanalized the RCA CTO, and then remeasured the FFR of the LAD. And the FFR of the LAD was 0.83, like Dr. Berlakis said. So this is then an individual who had CTOs of 2 arteries, had ischemic cardiomyopathy, an LAD that was non-ischemic. And this is a nice review that was written by Dr. Berlakis and his colleagues. And it nicely demonstrates the physiology of a donor artery to an occluded segment via collaterals. And the CTO segment really is maximally vasodilated. And when you give adenosine, it causes a steal, which would artificially show you that the donor artery is ischemic. And then they come up with a very nice algorithm. A few small studies have shown that really there's a small proportion of patients who would really be reclassified from true ischemia to non-ischemia. It's usually in the order of 0.04 to 0.07. So if it is, say, the LAD had truly an intermediate lesion and the FFR was, say, 0.62, it would be highly unlikely that that was related to collateral flow. That would really signify that the LAD indeed is ischemic. But like the case I demonstrated, the FFR was truly in the gray zone. We opted not to image and stent the LAD because this was a 20-year-old stent and actually looked pretty darn good for a 20-year-old stent. And we didn't feel that that was contributing to the left ventricular dysfunction. So again, this case demonstrates coronary steal. And we talked about the physiology of that. There's a lot of work that is done in this area, but I thought this was helpful because going in, one would misconstrue this as ischemia of the LAD. The patient would, in many instances, be sent for bypass surgery. And if the LAD truly is not ischemic, after bypass, the lima may actually never mature. Thank you.
So question is, if the FFR of the LAD was in the borderline zone, and the surgeon said, yes, we can do a CABG, would you send them for a CABG?
That's actually a great question. If it was truly in the borderline zone, would I send, at the end of the day, we had to define what kind of a cardiomyopathy this was. And I still believe this was ischemic cardiomyopathy. This is a guy who'd had an infarct 20 years ago. Now, part of the reason why the LAD was non-ischemic was a lot of that myocardium was probably infarcted. So if this was, let's just say, an LAD that was supplying a completely viable myocardium, then for that 56% instant restenosis, we would have expected a truly ischemic response. Now, is there any evidence that fixing this would reverse his ischemic cardiomyopathy? As you know, severe LV dysfunction, multi-vessel disease, I'm not sure how much evidence we have to really fine-tune that, but we've recanalized them. We will see, and you can see between the first cath and the second one, which were 6 days apart, the electrophysiologist already decided that they were going to put an ICD because the patient had had a few runs of sustained ventricular tachycardia. And we were not hopeful that by recanalizing the RCA and the OM, we would improve his EF from 15% to above an ICD threshold.
Perfect. No, thank you so much. Any other thoughts? I know this is a very complex case. The CT always confuses people a lot, I think. But any other thoughts, or would you do anything different on this case, Haider?
Not really. I think introducing these patients to CABG would have been probably a tough decision for me to make, especially with all the data, but a great demonstration of CTO. I always thought about this. I believe the data, then I stopped believing the data. But now you see, you have to believe it's, I think CTO physiology is quite significant. I always ask myself, probably Dr. Blakis, you know this answer. I don't know if the effect is an immediate index procedure, or sometimes it takes time for fibrosis or remodeling to happen. That's what I struggle with all the time. We're lucky, great demonstration that the FFR immediately reversed. I think because the LAD territory was not viable much, and then the CTO was stealing a lot. But cases, when the LAD is more viable, I think it probably requires some time for the FFR to switch once you open the CTO. I'm not sure, just a hypothesis.
Actually, there have been cases, and actually as time goes by, as you're right, the microcirculation recovers, so things may change 6 months down the line compared to now. So I completely agree. Well, it's 9 o'clock or 10 o'clock Eastern time. So again, I would like to thank everyone. Phenomenal cases, excellent discussion. Thank you so much for participating on tonight's webinar. And again, there's CME online. We'd like to thank our sponsors, Abbott, Boston Scientific, and Medtronic. Thank you all again, and looking forward to see you at CVI next month. So thank you so much.